We're almost down to the end in neurology, and here we have the last couple of sections. We have myasthenia gravis and dementia as the last two sections. Now, myasthenia gravis is basically an autoimmune disorder where you're attacking your own neuromuscular junction. Why am I all of a sudden allergic to my own acetylcholine receptors? The answer is nobody knows. When I'm allergic to the myelin of my peripheral nerves, it's Guillain-Barré. When I'm allergic to the myelin of my central nervous system, it is multiple sclerosis. When I'm allergic to my acetylcholine receptors, it is myasthenia gravis. And my muscle, A without stenos. Stenos is the ancient Attic Greek word for strength. Thrombasthenia means platelets without strength. Neurasthenia means nerves without strength. Myasthenia means muscles without strength. So what is the strongest muscle in the human body? The strongest muscle in the human body is actually, in men, it's the masseter, and in women, it's actually the uterus. But we don't squeeze our uterus too often, except when giving babies. And since that's modified smooth muscle, since it's not a skeletal muscle, it actually doesn't get affected as much by myasthenia gravis because it's not working off a neuromuscular junction. So the strongest muscle in the human body that we use is the masseter, so people present with the decreased ability to chew. All men swallow, but Fu Manchu. And you're using it because in an increasingly obese society, as we get larger and fatter than I thought, you're chewing is some of the only muscles that you really exert on a day-to-day basis. The other is your eyes. We don't realize how complicated the movement is to keep your eyes in a particular spot, to look at something, to read, to get your eyes to move with even saccades, and even to focus on me now as I'm speaking to you, looking at me, is a complicated coordination of muscles that are skeletal muscles around your eyeballs. And when those extraocular muscles fatigue, you get diplopia, double vision. The individual eyes are actually normal. So the vision in one eye, if you covered it, would actually be fine because it does not affect the pupil. Myasthenia gravis does not have a pupil effect. It doesn't block the ability to constrict or dilate the pupil, but it does affect the skeletal muscles of the extraocular movements, and that's why your eyes get fatigued. That is why you get ptosis, because that is skeletal muscle. Now, it might be skeletal muscle innervated by cranial nerves, but it's still skeletal muscle. So look for a patient that's described as decreased ability to finish meals and chew, worse towards the end of the day, and double vision diplopia. You're seeing two of people. That's what the question is going to describe. For you to be able to answer the question, what is the most likely diagnosis? Myasthenia gravis. Double vision, decreased ability to chew. Thank you very much. Now, the best initial test is something that people often don't get right. They want to say things like edrophonium testing. But edrophonium testing is good maybe if you have a very specific thing like ptosis, and edrophonium testing is okay for ptosis because you can actually measure something. You can actually say, okay, look up, I can't look up, okay. Now we squirt you with edrophonium and it's like, ding, I can look up. I can see clearly now that my myasthenia is gone. So the thing is though, is edrophonium testing is not as sensitive or as specific as acetylcholine receptor antibodies. Acetylcholine receptor antibodies are both more sensitive and more specific than edrophonium or tensilon testing. Then what is the best initial test? Acetylcholine receptors. What is the most accurate test? Is single fiber electromyography. What is the most accurate test? Is a single fiber electromyography. electromyogram. What is the most initial test? Acetylcholine receptor antibodies. What is the most accurate test? Single fiber electromyography. Now, acetylcholine receptor antibodies will be present in 80 to 90% of patients. What are you going to do for the 10 to 20% for whom they are negative? We have another test called anti-musk. What makes the muskrat got its musk? Courage. Muscle-specific kinase. Anti-muscle-specific tyrosine kinase. And this is a unique antibody, unique only to myasthenia gravis as a diagnostic test. All the other tests that some of you may have heard of about putting ice packs on the face, not good enough, not sensitive, not specific. Acetylcholine receptor antibodies, anti-muscle specific kinase, single fiber electromyography. Edrophonium is a functional test that's sort of passé. If you were told that this was the first test to do, you're just about 25 years out of date. That's why you came to see us. So everybody at the beginning of myasthenia gravis is going to get put on pyridostigmine and neostigmine. And pyridostigmine and neostigmine increase acetylcholine by blocking the metabolism of acetylcholine. So you get more acetylcholine, less receptors. More acetylcholine and less receptors, so you have an increase in your strength. Now, over time, what does pyridostigmine and neostigmine do to the progression of your disease? Over time, what does it do to the progression of your disease? And the short answer is nothing. What does it do to the progression of your disease? And the short answer is nothing. It does nothing to the progression of disease because all it does is increase the supply of acetylcholine. So therefore, everybody on pyridostigmine and neostigmine eventually will progress. Eventually, they're gonna get worse. They have to get worse because you haven't done anything to affect the underlying pathology of the disease, which is don't let me get me, I'm a hazard to myself, I'm making antibodies to my muscle receptors. So therefore, if you're gonna progress, we wanna say that if you're medically young, which is about under 60, 70, you should have your thymus taken out, thymectomy. And what we see is that when you take your thymus out, 70% of patients actually improve. They markedly improve. If you take out your thymus, 70% of patients will have a marked improvement because you're no longer manufacturing the antibodies against those receptors. Now, when I say it has to be done medically young, which is under 60, 70, 70, 75, it's because by the time you're 70 or so, your thymus has reabsorbed to being almost a nothing. It's a little fat gland on the top of your heart, and it becomes basically involuted nothing. So if you're too old to get the thymectomy, too old for the thymectomy to improve you, because thymectomy is to myasthenia as spleenectomy is to ITP, immune thrombocytopenic purpura. Thymectomy improves long-term in myasthenia gravis. Spleenectomy improves long-term in immune or in idiopathic thrombocytopenic purpura. Or if you're too old to get the thymectomy, we use steroids while we're waiting for you to get the effect of other immunosuppressive medications like azathioprine, immunosuppressive medication, 6-mercaptopurine, basically the same drugs, like cyclosporine, inhibit your T cells, inhibit your T cells, inhibit your T cells, tacrolimus, sirolimus, tacrolimus, sirolimus, pimecrolimus, cyclophosphamide, mycophenolate, inhibit the T cells, inhibit the T cells, inhibit the T cells. We use steroids while waiting for other T cell inhibiting medications to take their effect. Now we use cyclosporin, tacrolimus, sirolimus, pimecrolimus. We use cyclosporin, azathioprine in mycophenolate for the same reason that we use them in Crohn's disease or to prevent organ transplant rejection or in lupus nephritis mycophenolate. because they inhibit a selective, narrow part of the immune system, like just the T cells, and leave the rest of the immune system alone. That's why these are really important drugs, because they're selective immune system modifiers, because what's happening is that you're rejecting your own acetylcholine receptors, and this will just affect the T cells and leave the neutrophils alone, so there's less adverse effects. The final 2 or 3 things in myasthenia gravis is when you have an acute myasthenic crisis, acute, overwhelming, sudden weakness, especially to the point where you get respiratory disorder. It is rather like Guillain-Barré. Acute weakness, acute respiratory problems, and we use intravenous immunoglobulin or plasmapheresis. Remember, no combinations. You can't combine them because the plasmapheresis would remove the intravenous immunoglobulins. An intravenous immunoglobulin or plasmapheresis for acute myasthenic crisis. Now, here's the last 2 things that you're going to get asked, and they're isolated fact biopsies. What drug can mimic myasthenia? Next, what cancer do you have to screen everybody for? And these are 2 very important questions, which you will see. What drug can actually mimic myasthenic symptoms, and what cancer? The drug that mimics it is aminoglycosides, like gentamicin. Aminoglycosides in a small number of people can cause a myasthenia-like picture of inhibiting the neuromuscular junction. Did you know that? Yes, gentamicin, tobramycin, amikacin, gentamicin, tobramycin, amikacin. Next, the cancer that you have to screen for is cancer of the thymus, thymoma. You must look for thy mama. I'm looking for your mama. Thymoma. Thy Museum of Martin, Hart. Thymoma. So we do a chest CT while looking for thymoma and thymic hyperplasia, and those are the 2 cancers you have to screen for. What is the adverse effect of pyridostigmine and neostigmine? Adverse effects is consistently on step 1, step 2, step 3, and step 4, which is internal medicine boards. And the adverse effects of all that acetylcholine is salivation, lacrimation, urination, defecation, 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 United Nations. Glycopyrrolate. You ever heard of it? Glycopyrrolate. You ever heard of it? Glycopyrrolate is an inhibitor of the muscarinic receptors just in the mouth. It stops excess salivation. Now, I have somebody that I work with every day in the hospital, and she has myasthenia gravis. She did not get super better from her thymectomy, and every time she has to go up on her pyridostigmine and her neostigmine, she has terrible salivation and diarrhea. And we use glycopyrrolate to prevent that terrible salivation, and diarrhea, so that you don't have these terrible adverse effects. Because what's the other alternative? She has to go on steroids. The thymectomy didn't work super great. Immunosuppressive medications or steroids. Ooh, steroids, loads of adverse effects. Glycopyrrolate. If you know about glycopyrrolate, now let me tell you something here. I mean, one of the occupational hazards about being me is that you think that because I'm so exciting, which I am, that you don't need to go study and look it up right away. But you're not going to take a complicated name like glycopyrrolate and just instantly know what that is unless you go look it up and confirm it. Go to Wikipedia. Keep it superficial, but look it up. The doctor can't prescribe a medication that he's never heard of. Peace.